This week on the BackTable Podcast.
If I cannot get a sense of the entirety of the tumor, if I'm concerned certainly about a malignancy, if it's a question of maybe bony involvement, I like CT scan with contrast. I read those often. I feel comfortable interpreting those myself. MRI is really great if you're worried about potential nerve involvement, like perineural facial nerve invasion. And so that is a really good option there. I will say in general, I don't read MRIs as much, so I do in those cases rely heavily on our neuroradiologists, their interpretation, and sometimes we'll review it together to get a sense of the extent of the tumor and relationships to the surrounding structures.
We have a great guest that we get to chat with today as well. Today we are joined by Dr. Mirabelle Sajisevi. She is a head and neck surgeon at University of Vermont Medical Center, where she is also the residency program director. And she's here today to talk to us about parotid malignancies. Welcome to the show, Mirabelle.
Thank you so much for having me. And maybe I can also request you to introduce me to all my patients too every day.
That's what I do. I just fly between Dallas and Burlington and just it'd be awesome. It'd be great. Before we get into parotid malignancies, tell us a little bit about yourself and your practice.
Oh, sure. So after completing residency in otolaryngology, I pursued a head and neck oncology and reconstructive fellowship at the Mayo Clinic in Rochester. And subsequently, I came on as head and neck faculty at the University of Vermont. That was in 2017, and I have been here since. So I actually see and treat all aspects of head and neck pathology, ranging from head and neck squamous cell cancers to disorders of the thyroid and parathyroid, and of course, salivary glands. And today we'll be focusing on parotid malignancies.
And this conversation came about because you and Gopi both completed your triothesis this year, right?
Well, yeah.
I was fortunate enough to be standing next to Gopi. She just made it, just enhanced the experience.
Yeah, we had a lot of fun together because you're standing there and you're getting these handshakes of I don't know, it was great because there was probably, over 100 people or more that showed up. And so we got to chit chat and hang out. Mirabelle, though, hers was with distinction. Her trio was, awarded with a distinction. So congratulations on that.
Oh, thank you. And congratulations to you as well.
Yeah. It's a lot of work, you guys. So y'all are powerhouse ladies getting it done.
So Mirabelle, tell us a little bit about your parotid malignancy practice. How often, is a parotid mass a malignancy when it comes to you? How are these patients referred to you?
Yeah, so in general practice, the rule is sort of 80%, 20%, where most of parotid tumors are statistically benign at 80%. And generally speaking, I would say my practice is similar. I do think that maybe in some tertiary referral centers, they might see more malignancies, sort of getting more referrals for more complicated parotid cancers. And so generally speaking, primary care providers are the ones that are referring to me. So these are often identified on imaging, as an incidental finding, or, patients may note the lump themselves, or they're just identified on routine physical exam. But University of Vermont is sort of the only tertiary referral center in Vermont. And so we do also get a lot of referrals from our affiliate hospital ENTs, who may just not do a lot of salivary gland surgeries. And so then will also be a referral basis for us as well.
Yeah, that makes sense. Yeah, I would agree that in my experience, that incidental finding is super duper common because, and older patients get scans for various reasons. They went to the ER because they fainted or fell down, and then they got a scan, and then there's a parotid malignant or a parotid tumor.
100%.
And so as you're seeing patients in clinic, what are the important things as part of your history and physical that you're looking for?
Yeah, definitely. I mean, the key questions to always ask are, how long has the mass been present if they're aware of it? Sometimes they may not have known at all, given it was incidental. Sometimes I'll try to look back and see if they've had imaging before that happened to show it, just to get a sense. I'll ask the patient if they are aware of the mass, have they noticed any change in the size? Really important are things like pain, if they have any facial nerve symptoms like weakness, twitching, any numbness of the face. And definitely questions about their history as well. Have they had any prior radiation exposure, autoimmune diseases, and skin cancer is also a very important one, not necessarily for a primary parotid malignancy, but the parotid can also be a source of a lymph node basin for metastasis for cutaneous malignancies as well. So that's important to ask. And on exam, definitely trying to get a sense of the mass characteristics. So the size, mobility, if it's sort of fixed or you're worried that maybe that could be a sign it's malignant and it's invading into deeper structures. Certainly evaluating facial nerve movement and make sure the facial nerve branches are intact. And doing palpation, bimanual palpation of the neck to see if there's any lymphadenopathy. Those are kind of the main important things during my initial encounter.
So if you do have a patient that, let's say the 50-year-old gentleman that had the incidental finding in the ER, and there's, a 2-centimeter mass in their parotid, and let's say other than that, maybe they had a little bit of swelling that they've noticed in that area, but no pain, facial nerve is intact. What's part of your differential and what are some of the next steps that you would do for this patient?
Yeah, definitely. And one, sort of past medical history thing to also note is, prior history of tobacco use, because that can certainly be something that is associated with one of the benign tumors, a Worthen's tumor. So, I'm thinking it's always good to sort of start off with a broad differential in your mind. So benign tumors, like I mentioned, Worthen's or pleomorphic adenoma, but of course, a malignant primary salivary gland malignancy. But then, as I mentioned, also metastatic tumors, squamous cell or melanoma. And then you can also develop lymphomas in the salivary glands as well, often associated with a history of Sjogren's. And then there can also be, inflammatory or congenital lesions like branchial clefts. So just kind of keeping an open mind and not jumping to conclusions.
Is there a difference in presentation or exam if it is a metastatic from squamous cell or melanoma?
Certainly with squamous cell cancers, I would say that tends to be more aggressive. They've never had a mass, and then all of a sudden, something's developed and it seems to be rapidly changing. And certainly if left unevaluated and untreated, it can do things like erode through the skin, cause facial nerve paralysis. And so those metastatic squamous cell cancers can be pretty aggressive. Whereas in contrast to sort of what you described, sort of a 50-year-old, sort of a painless mass, maybe it's been there for a couple years. I'm definitely thinking that that's more likely to be benign, of course, or, even a low-grade malignancy, because those can be relatively indolent and slow growing in certain cases as well.
Yeah, thinking about metastases, do you do like a scalp exam? Down here in Texas, I remember in residency, we would have, patients who would have, it's like the farmer that's had, like tons of sun exposure and they get these, scalp squames and don't complain about them. So if you don't actually look for it, they're not going to be like, oh, hey, and yeah, I have this like sore that's been here for a year.
You're absolutely right. And I will say, in the context that I see it most in is a patient will have had a prior history of multiple cutaneous malignancies, or to your point, you see, and they just have diffuse sun-damaged skin, and they've been in the sun all their life. And we have a very great Mohs group, and they do a lot of great work. But unfortunately, sometimes those patients will develop a delayed metastasis. So we'll see that they just maybe had a prior Mohs surgery in the last 6 months to a year, and then they're develop, then they present with this mass in the parotid, and my suspicion is very high. That's sort of very on the top of my differential if they kind of have that history.
And so what's next? After you've done your exam, you're seeing them, you kind of have your differential in your mind. What are your next steps as you're working up these patients?
Absolutely. You can always consider laboratory testing. That's usually pretty limited, just basic labs or autoimmune markers. But I would say definitely for me, ultrasound is sort of the immediate next step. It's sort of an extension of my physical exam. We have them in our exam rooms, and that can give a lot of information very quickly and easily, and non-invasively right off the bat. So you can get a sense of certainly the size, the location, sort of, is it well circumscribed, or or does it have indistinct borders? You're getting a sense, is this going to be benign or malignant? Or is it a vascular lesion, that kind of thing? And then ultimately, though, even as good as ultrasound and other imaging modalities are, biopsy is definitely needed to get a sense of, is this a neoplastic versus non-neoplastic lesion? And that really will guide the next steps.
If the patient comes to you already with CT or MRI, are you still also performing ultrasound? And does that give you extra information that might change your decision-making?
Yeah. So if patients come with a CT or MRI, that's great. That's additional information that we'll definitely take into consideration. But again, I just love ultrasound because for one thing, it's definitely, I would say, more sensitive in evaluating lymph nodes. So I'll always use it, of course, to evaluate the parotid lesion, but immediately go and look at the, level 1, level 2 lymph nodes to see, because even lymph nodes that have, a small amount of micrometastatic disease, you can see changes in the appearance on ultrasound, even though the lymph node itself is not overtly enlarged. So you'll lose the fatty hilum, it might become more rounded. And again, that could certainly change your impression and how you're going to manage this going forward.
Cool. So even a lymph node that's like not enlarged by size criteria, with the ultrasound, you're having a higher suspicion for metastasis based on what it looks like, and that might change your treatment.
That's exactly right.
Yeah. Do you do your FNA in clinic? Like since you've got your ultrasound, do you just needle it right there, or what's that workflow look like?
Yeah, exactly. And up until about a year or two, that's what I would do. I would do the FNA, put it on sides, send it to the lab, and sort of, hope that I got a diagnostic sample. And I always did it under ultrasound guidance, just to make sure I'm within the lesion, or if there's sort of necrotic areas, try to get the solid portion. But actually in the last, I would say now maybe 18 months, we developed a cytopath clinic actually within the ENT office. So our cytopathologist techs and pathologists come up and they assess the slides in real time. So they let us know, did we get enough cells? And they get a preliminary sense of what the lesion might be. And that helps, do we need to get more for additional testing? So that's actually been really great. I think it's increased our yield and sort of, accuracy, which is always helpful to get as much information as you can for next steps.
So is that part of the same day patient visit, or do you have to book them like in a week or whenever you have extra time for that? How do you do that?
Yeah. So back in the day, we would have to sort of say, hey, we're going to bring you back with the pathologist present. But now this is sort of a designated, day that I have each month. And so when patients are referred for a mass, it either parotid, thyroid, neck mass, that hasn't been biopsied yet, we place them in that slot, and that way it's a very efficient visit for the patient, and we can give them some, preliminary information in real time, which they really appreciate.
Yeah. Is there any controversy about parotid lesions and whether to FNA or not, with spillage and things like that?
That's a great question. I would say that FNA is very safe. If in 2021, ASCO released guidelines for the management of salivary gland malignancies. Actually, that was kind of the first real guidelines that have been published on management. And one of the recommendations is that providers should perform a biopsy, either an FNA or a core needle biopsy. I will say that I typically lean towards an FNA. Core biopsies, I think, theoretically may have a higher risk of seeding. So generally only use those in select cases. And also the other thing is the higher risk of bleeding and, theoretical risk to the facial nerve. So FNA, we can do them safely even when patients are on anticoagulation. And really the reports of seeding are sort of almost non-existent. So definitely worth doing to try to distinguish neoplastic from non-neoplastic.
And so kind of talking more about your FNA results, talk to us a little bit about diagnostic challenges and, when you get uncertainty, when you kind of have those results that are in that gray,
Yes.
fuzzy zone of like, okay, now what do we do?
Definitely. So certainly false negatives can occur, and sometimes low-grade malignancies can resemble benign tumors cytologically. The Milan classification was published in 2018, and it has 6 categories of results for FNAs, similar to Bethesda classification for thyroid nodules. And it's recommended that pathologists should report the category of the result and the associated risk of malignancy. So, for example, Milan class 2 is non-neoplastic, and so it carries a 10% risk of malignancy. So that's, again, no test is perfect, but you generally, feel pretty good about that. Whereas if you have suspicious for malignancy, then the risk of malignancy is 60 or 90% respectively. And so, certainly malignant, that's high risk, and you're certainly going to proceed with treatment. As you mentioned, the tricky areas are those fuzzy ones, which are atypia of undetermined significance, which is category 3 in the Milan system, and then salivary gland neoplasm of uncertain malignant potential, also known as SUMP, the dreaded SUMP. So that carries a 35% risk of malignancy. And unfortunately, I tell patients that it's really the only way we're going to know definitively at this point. May require resection for definitive diagnosis, and it may also be the definitive treatment as well.
So for this patient, let's say they never came in with CT or MRI, they're in your clinic, you did the ultrasound, you see something on your ultrasound, you decide to go ahead and get an FNA. How do you decide, let's say I don't know, I feel like I have 10 questions right now. Let's say you have a class 2. Do you just follow up with them? And then let's say it is like a class 4 where maybe the risk of malignancy is higher. And so you're like, okay, we probably need to plan for surgery. How do you then get CT or MRI? Is that part of your workup?
Gotcha. Great. Those are excellent questions. So to your point, starting with your question of non-neoplastic, I look at the whole overall picture. Like, does this make sense? Looking at the lesion, looking at the patient, looking at the history. If it feels like it can fit, great. But I still generally do follow up patients, usually with ultrasound. Again, if I feel like I can get a full picture of the lesion. There are tumors, if they're in the deep lobe, sometimes they're actually difficult to appreciate really well on ultrasound. And in those cases, I definitely have to rely on a cross-sectional imaging to get a better view of that. And sometimes you have to do those serially to see if there's any growth or change. But to your point, you can have false negatives, I think up to 15, 17%. And so I do like to follow them just to make sure that there's no changes that would make me sort of switch gears. And then in the situation of something like a SUMP, what we do next also depends on what else the patient may be facing. So as we talked about, oftentimes these are discovered incidentally. Many times on PET scan, they're being worked up and they have this other cancer that is, maybe more aggressive and being treated. And they have this, let's say the patient has this, well circumscribed, it's FDG avid, but they have, long-standing history of smoking. It's an elderly male. I may suspect that it's like Warthin's, or sometimes elderly patients have these oncocytomas. And so for those patients, I think, I favor that the risk of malignancy is on the lower side and they have more pressing needs that need to be treated, and I will follow them. Again, sometimes they're getting repeat PETs, so that's, inherently they're getting, follow-up. But again, ultrasound, if it's in a location that I can really, see it well, is another way that I may just follow them if we don't really feel like we want to jump to surgery given their other issues that are going on.
Does everybody need a CT or MRI? And which one of those do you like better?
Yeah. So I find, as I kind of alluded to before, if I cannot get a sense of the entirety of the tumor, and if I'm concerned certainly about a malignancy, If it's a question of maybe bony involvement, CT scan, I think I like CT scan with contrast, and I read those often. So I feel comfortable interpreting those myself. MRI is really great if you're worried about potential nerve involvement, like perineural facial nerve invasion. And so that is a really good option there. I will say in general, am sort of less, I don't read MRIs as much. So I do, in those cases, rely heavily on our neuroradiologists, their interpretation, and sometimes we'll sort of review it together to get a sense of the extent of the tumor and relationships to the surrounding structures.
Mirabelle, can you go into how, let's say you get your FNA, and let's say there is concern for muco-ep. On the FNA, can they tell you if it's low or high grade? And if so, how does that impact your management?
Yeah, I mean, sometimes they can tell you low grade versus high grade, which is if they can, you're like, wow, that's amazing. Yeah, exactly. Thank you. So that's amazing. Because to your point, if you knew going in, I think it would certainly impact my extent of surgery. So low grade tumors, you can do a sort of a more limited parotidectomy because they tend to not metastasize to intraparotid lymph nodes or cervical lymph nodes like high-grade tumors do. And so you may also not need to do a neck dissection. So it would be great. Whereas, if you knew it was a high-grade muco-ep, you'd certainly want to do sort of at least a complete superficial, if not a total, and also a neck dissection, usually levels 2 through 4. But the problem is that they don't always have the ability to tell you, or, maybe intermediate grade, and so you're kind of on the fence. And so in those cases, there could be a role for frozen section intraoperatively, so one example would be that since level 2 lymph nodes are right in your region of your operative field, you could remove some of those, send those for frozen section. And if they have metastases, then you know that you have to actually do the neck dissection.
Can you talk to us a little bit? Because is this sort of where you did some more research for your thesis, for your trio, in terms of low grade and intermediate grade, in terms of practice patterns?
Yeah. Well, exactly. So for that paper was looking at practice patterns and management of low to intermediate grade tumors. The caveat being that this was looking at the practice before the ASCO guidelines came out, just to kind of see what folks were doing. And the sort of neck dissection practices was pretty variable. So basically, about 37% of patients underwent an elective neck dissection. So these are clinically N0 patients. And it varied what levels were done. So certainly most commonly level 2 was dissected, followed by level 3. And I think the variation it kind of goes back to the problem of not necessarily knowing the diagnosis or the grade when you go in. And so no one's universally doing it or not doing it because it can be hard to make that call. And so that's why I mentioned, I think many folks, including myself, will do frozen section just to give some guidance on that.
And this may be a dumb question, but is there anything analogous to like Afirma testing for salivary gland malignancies for indeterminate, to kind of help give any sort of sense of likelihood of malignancy?
Yeah, no, that's a great question. I think that, we're not routinely doing this, but I think there are some folks that are sending off for special staining or, molecular testing to see if, to your point, can you get a little bit more information about the tumor. So it's something that may happen more and more as time goes on. But right now, basically, I counsel patients on this is a limitation of FNA and, either observation or surgery, depending on the factors we discussed.
And so as you're, doing that surgical planning discussion, particularly for these intermediate where we're just trying to decide whether or not you need to do take out the tumor and address the neck, can you talk to us how that discussion goes and, kind of like the nuances of like, if we just take out the tumor, there's a chance we may need to go back or we may need to treat the neck somehow at some point versus, doing a more extended surgery that you may, in hindsight, not have needed.
Yes, absolutely. And this is where I think talking to patients and counseling them about risks and benefits is obviously important with any surgery, but I feel like particularly for the parotid malignancies, just because of the impact it can have on form and function of the face. And I think the more that the patient is sort of aware of the possibilities and the potential outcomes, then and have the right expectations, everyone's going to be happy, with the outcome. So I think but of course, I think the counseling that happens on what might happen depends, of course, on the presentation. So if there's sort of this small, well-circumscribed mass that is a sump, I'm not going to we always talk about the risks of parotid surgery. So, bleeding, infection, sialoceal phrase, numbness, facial weakness, paralysis because of the proximity of the facial nerve. But, I'll be telling them that the facial nerve sacrifice needs or, extensive neck dissection or reconstruction are very low, in that situation. Conversely, you have a patient who comes with this sort of rapidly growing mass. Their imaging is highly concerning for a high-grade malignancy. I'm really going to have a long discussion with them about the possibilities of a extended resection that may involve resection of the facial nerve that will subsequently then require reconstruction, both of the facial nerve and potentially soft tissue. Make sure that you have your appropriate colleagues as sort of available to help in those scenarios, including a neurotologist in case you need to sort of drill out the facial nerve and discuss things about potential adjuvant therapy and rehabilitation as well. So it's a long-winded answer, but it does depend on how their presentation is. But to your point, I think it is so important to really anticipate what you might need to do, what you might encounter so that you can accurately have that ready and have the patient ready for that. Because there's no worse feeling of finding that for the best oncologic result to sacrifice the facial nerve and you didn't have that discussion with the patient and you're in the operating room and they're on the table and you have to make that hard decision.
And for the case of a sump, do you do 1 centimeter margins or whatever the standard margins are for a malignancy? Like, do you go ahead and do like a wide resection for a sump?
Yeah, no, I'm glad you brought that up. So generally speaking, as with all head and neck cancers, when you are removing a parotid tumor, the goal is definitely negative margins. However, due to the relationship of the facial nerve to the parotid gland, close margins are quite common given the dual aims of tumor removal and nerve preservation. And so, certainly in a benign, but in a low-grade salivary tumor, there's actually mounting evidence that close margins, even in context of close margins, patients have excellent local control. So again, obviously, while wide margins is nice, you're not always going to, be able to get that. And turns out in many of these low-grade tumors, that's okay.
And for let's say you have like a pleomorphic and I feel like when I was in residency, it was always like, don't get into the tumor. Like, there's like cystic parts, and you don't spill tumor and da-da-da. Like, can you talk about, risk of recurrence in those situations? Like wanting to like take enough to where you're not risking getting into it versus like not taking a huge margin to create a defect.
Yeah. So I can't quote like actual percentages of risk of recurrence, but that was sort of my experience as well, is like, oh my gosh, like don't spill the tumor, whatever you do. But just going back to the relationship of the nerve and the parotid gland, I mean, sometimes the tumor capsule is literally sitting right on the nerve. And so, but there's a plane, there's a plane between the capsule and the nerve. And of course, especially in a benign tumor, but even in a low grade tumor, if there is a plane, you definitely want to save the nerve and just peel the tumor away, even though you might feel a little squeamish about that it's such a close margin. And then in my mind, if you're close, obviously you're maybe within a millimeter, there's really not a point then of taking excess tissue on the other aspects of the tumor, so like on the top or bottom or superficial, because I mean, your closest margin is your closest margin, I think somebody once said. So I think that doing more limited parotid surgeries, including extracapsular dissection, is appropriate, again, as long as you are keeping the tumor intact and removing the whole thing in its entirety. And obviously the less dissection on the nerve, the less, neuropraxia. And that we also found that in our paper. I mean, not surprisingly, total parotidectomies are going to have more weakness than, less extensive parotidectomies. And then also that will also reduce your need for them having a soft tissue deficit, or you needing to do some type of reconstruction to address a soft tissue deficit.
Is that the context of kind of distinguishing the management of a superficial versus a deep lobe tumor? Meaning, if it's deep lobe, I'm probably gonna need soft tissue management. Like, it may be more difficult with the nerve. Like, tell me a little bit about those nuances.
Yes, that's a great point. So if I can determine, I mean, again, we talked about anytime you do parotid surgery, you're counseling the patient on wrist to facial nerve. But I do tell patients, if I can appreciate that the tumor is in the deep lobe, I basically say you will have paresis, because in order to get that tumor out, you are sort of doing a extensive manipulation of the nerve, trunk and often all the branches to sort of deliver the tumor out. So I sort of say that is going to happen. And again, I think it's all about expectations, because if they go in, they're like, okay, and they wake up and they're that way, they say, well, that's exactly what you told me what was going to happen. That being said, interestingly, there have been some times where for a deep lobe tumor, in terms of a soft tissue deficit, you can actually lift the superficial lobe off, work on the deep lobe, get that tumor out, and actually just lay the superficial lobe back down and have a good cosmetic result. But in the case where the tumor is, such a way that you do have to remove the entire parotid gland, then I definitely think that soft tissue reconstruction is really important to achieve a good outcome for cosmesis, because that total parotidectomy, they will be very, very sunken in, and it gets worse over time. Yeah.
Can we talk about that, since you brought it up? How do you like to reconstruct that defect?
Yeah, so that answer is it depends. So it depends on a number of things, including the patient themselves, what also their motivations, their medical comorbidities. Another important consideration is, are they going to need adjuvant radiation? Because in those cases, I think a robust sort of vascularized flap is really important. So, let's talk about benign lesions. So let's say you have a benign lesion, but it's pretty big. And so your resulting soft tissue deficit is big. Options include alloderm, if it's not a huge deficit, but I've used that to create symmetry where I thought that they're, in a young, healthy patient with a benign tumor. And I've been happy with that. Of course, there's a risk of infection. And I do, knock on wood, have not had to go back in that setting. But I've been told that, unfortunately, that's a very difficult dissection if there's alloderm in there. Similarly, I think just in terms of if it's a cancer, follow-up surveillance can be more challenging. So again, I think in those cases, doing a soft tissue flap is helpful, which can range from just a free dermal fat graft, like from the abdomen, or one nice flap that I actually really like is the submental flap, particularly in a patient who you'll be having to do a neck dissection anyways. You sort of extend the incision a little bit onto the neck, but everything is hidden into neck creases, so limited morbidity, limited additional time in the hospital, and you can deepithelialize it and bury it. Or if you had to resect skin, then it can also provide skin as well. But if you need something more extensive, then oftentimes a anterolateral thigh flap, I know that that's a choice that a lot of people like and is a good option. But of course, that requires microvascular expertise.
In terms of recon, we do it for cosmetics, but we also do it to prevent...
Like Fry's syndrome or Fry's.
Yes, for Fry syndrome. Thank you.
Oh, yeah.
Yes.
Yeah. So the thought is certainly that Fry syndrome is a result of after elevating the skin flap and then putting it back down with the same neurotransmitters. Instead of making saliva when you eat, of course, you sweat. And so the thought is that if you do place a, soft tissue barrier in your closure, that should decrease the risk. I think that's what is reported in the literature. I must say, I haven't seen it frequently, or it's at a level that's either subclinical or something where a patient says that they're really not bothered by it. So I guess that was a long way to say that I don't necessarily think to use reconstruction as a way of minimizing frays, although, it probably does. Definitely using it more for, contour of the face, especially, again, too, if a patient's going to need radiation, that's really important.
And then going back to the facial nerve, in what situations or what factors have contributed to where you've been in the OR and the tumor, you weren't planning on taking the nerve based on your preoperative assessment and information, but it doesn't have that clean plane. It's kind of sticky or adherent. How do you manage those situations in the OR?
That is one of the really tougher questions. And when you look at the ASCO guidelines, they say, okay, surgeons should perform facial nerve preservation in patients with intact facial function, and you've got a clear plane. You're like, well, yeah, of course. And then surgeons should perform resection of involved branches in patients who have impaired facial function or, they're encased in tumor. You're like, well, of course. But it's like, to your point, there's so many times you get in the OR and you're like, well, the nerve looks a little funky, but I can kind of peel. I mean, I'm getting the tumor off of it, and you're like, am I really going to take the main trunk? So so it's like on paper you're like, oh, this looks easy, and then in the OR it becomes really challenging. That's another situation where frozen section may help you, both in two ways. As mentioned, you may not have a diagnosis of a salivary gland malignancy going into the operating room. And then you go in and you see, okay, this clearly looks like a malignancy. It's really intimately sort of looking like it's involving the nerve. But before you even think about taking that nerve, you need to know that you're dealing with a salivary gland malignancy. So that is an opportunity to send for frozen and say, is this a malignancy or not? And I think oftentimes they're able to tell you, yes, this is a high grade tumor, but the pathologist won't, don't ask them exactly to tell you which type of subtype it is, but they can certainly many times help you and say that it is a malignancy. And furthermore, you could sample, a portion of that nerve to ask the question of, is there neural involvement? And those things can help guide you to make that decision. Now, I'll say, if you, confirm those things, then it's never an easy decision, but it's the right one. I think the harder ones are, like maybe they don't see definitive neural involvement, but the nerve just looks so abnormal. And I think it's sort of a judgment call. Sometimes I'll even ask a colleague if they're around, if they can come take a look, before doing something like that. And I think for me, certainly if I'm having to chew through tumor and, like the nerve is coursing in the middle of it, I just think that you're going to be leaving an unacceptable amount of tumor behind. And that unfortunately, in those cases, you have to make the hard decision of sacrificing the nerve. But hopefully, you've talked to the patient about that possibility. You have all your key players lined up, and then you can feel like you're doing the right thing and giving them the best outcome.
Yeah, because at the end of the day, it's a cancer surgery. Like, you're trying to remove cancer, even though it just feels wrong to cut a facial nerve.
Yes. Yes.
If they do have to take some facial nerve, and maybe it depends on how much and where, but is it like interposition grafts? Are we prepping the leg for sural? Like how, and granted, this is probably where your recon partners come into play, but talk to me a little bit about that.
Yeah, sure. So as you mentioned, great auricular nerve's right there. So that's a nice choice as long as it's not involved in the tumor. So yeah, doing cable grafts with that is a good option. Sural nerve, of course, is another good option. Or if, let's say, you're doing anterior lateral thigh, then the vastus nerve is right there. So that's a good option as well. The other thing that is, I think, being done more frequently with good outcomes is the masseteric to facial nerve transfer. And so that's it provides a dynamic bite-driven smile. So it does require some physical therapy because it's not how we naturally smile. You have to kind of learn how to clench your jaw to smile, but the outcomes are really great with that. Some cases, and some of these, you're doing all of these things. It's not just like one doesn't preclude the use of another, but even static slings, those are also tried and true and still have a role. So like a mid-face sling with either alloderm or fascia lata. And I will say, sort of in our practice, so of course then there's paralysis of the brow or lag ophthalmos. I usually refer those to our oculoplastics colleagues who kind of subsequently will manage that after their sort of main operation, and they do a great job.
And then just addressing the neck, if you do have a patient that has a malignancy and you need to do a neck dissection, how, are you doing all the levels, some of the levels, the ones that you've identified, suspicious lymph nodes? How do you think about that?
Yeah, so two things to think about are the status of the neck itself. So certainly if there's nodal disease present, you're going to do a neck dissection. And of course, you'll want to include all the levels that have nodal disease, but let's, at least 2 through 4. But obviously, if there's disease in levels 1 and 5 as well, you're going to include those. The question of an elective neck dissection, so if a patient is clinically N0, then you're kind of thinking about the primary tumor. So is this a high-grade, high-stage tumor? If you know that information, then even in a clinically negative neck, those you would want to do an elective neck dissection. Again, generally levels 2 through 4, because studies have shown those are the highest rates of metastasis and should be addressed.
And so let's say post-op, you've done surgery, you got path back, and let's say it's either intermediate or high grade. When do you start considering radiation? Do we have a role for chemo or immunotherapy or other types of targeted therapy? What's new and how is that managed or thought about?
Yeah, so definitely radiation. Many studies have shown that radiation therapy increases local regional control in the cases of high-grade, high-stage tumors, positive margins, perineural invasion, lymphovascular invasion, nodal disease. So that's really important. Chemotherapy, that's a big question that retrospective studies have not universally shown a clear benefit. And so the ASCO guidelines say that addition of chemotherapy may not be routinely offered outside of a clinical trial. So there was actually a phase 2-3 study that looked into this, RTOG 1008. Actually, randomizing patients to receive adjuvant chemoradiation versus radiation alone. So that has finished accruing, and they're, in the follow-up phase. So it is, hopefully the results may shed some light on that question. So I will say that these patients, we discuss them at our tumor boards, and sometimes we still, like if we had a very nasty tumor, even though there's, not any clear data, sometimes we will still recommend, usually, cisplatin is sort of the standard. Certainly chemotherapy can play a role in recurrent metastatic inoperable disease. But again, the really hard part about this is that salivary gland tumors are such a heterogeneous group of tumors that it's really hard to give this universal chemo regimen because they're all so different. And so that segues into your other question about, what's new? Are there other options? And so definitely there's increasing interest in molecular testing and targeted therapy. So we don't necessarily do this routinely, certainly not in low grade tumors, but in high grade or advanced disease, recurrent disease, you can do next gen sequencing, and that'll sometimes give you information on certain fusions, oncogenes. And so one example would be an NTRK fusion. And in patients with this fusion, there's targeted drugs out there, larotrectinib, and that's actually, it's a TRK inhibitor and has shown good objective response rates. Another common thing would be salivary ductal carcinomas often are HER2 positive and androgen receptor positive, and can respond really well to trastuzumab and anti-androgen therapy. So those definitely, I think, playing more and more role in a lot of clinical trials out there evaluating these targeted agents. Interestingly, immune checkpoint inhibitors, which have been, certainly revolutionized treatment for many types of cancer, have not done that great with salivary gland tumors. I think some of these tumors are just sort of like an immune desert, like just the tumor microenvironment. And so these just haven't responded as well. Now, they're still doing clinical trials, combination therapies, things like that. So not saying there isn't a role, but it's just maybe not as impactful compared to some of the other head and neck cancers.
Okay. And from a surveillance standpoint, how often are you seeing your patients? How often do you need to do imaging? I imagine you're ultrasounding a lot of them when they come in for follow-up, since that's, a good tool that you have at the ready in your clinic.
Yeah, absolutely. This is also kind of consistent with the guidelines, but generally we'll obtain post-treatment imaging at 3 months post-completion of treatment, whether if it's surgery alone or completion of adjuvant therapy. And the imaging modality does depend on their tumor type and stage, basically. So, for example, adenoid cystic carcinomas, which have a predilection for neural involvement, might get MRIs as part of their surveillance. And chest imaging is also really important for them because of the propensity for distant metastasis, which, can occur even, a decade later. But lower grade tumors, let's say we had sort of a actinic cell carcinoma completely excised, that's going to, be a sort of a lower risk of recurrence. To your point, I'll do ultrasound in my follow-up, and that I'll look at the parotid and the lymph nodes, even though again, usually low risk of cervical mets. And I usually get follow-up imaging sort of annually for at least the first 2 to 3 years. And certainly in high-grade tumors, like high-grade salivary ductal carcinomas, oftentimes they might need PET scans annually because those can really met anywhere. And I usually, in the first 2 to 3 years, is sort of the highest risk of recurrence. So I'll follow them, every 3 to 6 months. And then after that, I'll follow them annually. And patients, they'll often ask, well, when can I stop following up? And, a lot of people use the 5-year mark, but I don't like to use the word cure. I like to use the word remission, just because even though when you get to 5 years, the risk of recurrence is very low, and that's great. But I mean, in my mind, it's not zero. So I, say, hey, great, you're in remission, but I always offer to continue sort of annual surveillance after that. And most patients will take me up on it. They like the idea of, just checking in, seeing how things are going. And I think that's really important too if patients have had like more extensive treatments, more extensive surgery and radiation, because you can really get some late side effects from the treatment. And so I think it's helpful to have ongoing monitoring, not only of surveillance, but just their symptoms and quality of life.
Can you tell us about some of the late side effects that you've managed with your patients?
Yeah, so typically people can develop late cranial nerve problems. And the other big thing is osteoradionecrosis. That's a really, really tough problem. For parotid malignancies, I would say it maybe is more in the temporal bone, but of course, in other head and neck cancers, the mandible, which is such a challenging problem to treat. So just being able to identify problems early, get them into rehab, or, do more conservative measures to hopefully help, prevent progression.
Yeah. Sometimes you've cleared, you're cancer free, but then now we're dealing with, the sequelae
survivorship,
of kind of treatment.
sequelae.
Survivorship.
Yes.
Yeah. So the work is not done.
Yeah. That's why they're your patients for life. Like you said, this isn't just a quote cure type of thing. There's always, really quickly, in terms of surveillance, you mentioned, Mirabelle, that probably like imaging annually for the first 5 years, depending on the tumor type, and that might determine the type of imaging. How often are they seeing you in clinic that first year or two out just for a physical exam? Are you still seeing them like every, 3 months that first year, just to kind of take a feel if you may not be ultrasounding every time or?
Yeah. Definitely a clinic visit every 3 to 4 months for the first 2 years, and then like maybe 6 months in the third and fourth year. And I essentially always do an ultrasound just because it's right there, it's easy, and I feel more confident in that exam, because again, I'm not going to be able to palpate a, 1 centimeter lymph node that's abnormal, but the ultrasound may be able to detect it. So I just feel more confident that, I've evaluated things just more thoroughly.
It's like part of your physical exam, like our scopes become part of our exam.
Right, yeah, exactly.
Yeah, that's cool. And so as we're rounding things out, like where do you see, the future going as far as treatment, precision medicine, management? What's on the horizon, or what do you hope for?
Yeah, I mean, there's, of course, AI is, just emerging quickly in all facets of our lives, including medicine. And there's a lot of things out there trying to harness AI, both in sort of diagnosis of salivary gland cancers, sort of a predictive tool, and also in sort of predicting patients' risks of recurrence, and therefore maybe you could tailor your surveillance a little bit better. There was one interesting article I read about from the University of Chicago that was actually using AI to analyze this gene expression data from adenoid cystic tumor samples. And they matched it against controls to identify potential drug targets. And so they did identify PRMT5, which is an enzyme implicated in epigenetic regulation. And they worked with a drug company to develop an inhibitor of that and sort of use that as a targeted agent in adenoid cystic carcinoma. And there was certainly some promise in their preclinical studies. And, I think they're doing some clinical trials. So bottom line is, I think AI and, targeted therapy and clinical trials, that is definitely where this is headed. And hopefully, and because we talked about just the heterogeneity of these tumors, being able to do next-gen sequencing and really trying to characterize that specific patient's tumor and precisely treating them hopefully will result in improved outcomes and, local regional control, survival, et cetera.
Well, thank you so much, Mirabelle. If any of our listeners want to reach out to you, if they have any questions, are you on any social media? And if not, that's okay. They can reach out to us.
Yeah. No, I don't. But I have email, and I'm always happy to, connect that way. And
awesome. Well, thank you so much
for taking the time. This is fun.
Thank you so much for having me. It was great to chat with you both.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.